what is a misnomer, and people think that it is a release. Actually, this is not a release. This is basically a technique where we do micro needling and micro fenestration, small holes in the flexor retinaculum for the smooth gliding of the nerve over the flexor retinaculum, and it will prevent further recurrence also. And as we have seen and we have published one paper also where the chances of recurrence are very low. In fact, second time we have not seen patient coming, and in our regular follow-up also we have seen very good results with this technique. Then why 5% dextrose? Basically, we should understand the concept of hydrodissection. 5% dextrose is best because it is safe for perineural use, and it inhibits TRPV1 receptor capsaicin sensitive, which inhibits the release of CGRP. And few evidence, very less evidence, and symptom relief is only for 1 month. After that, again there will be recurrence. So nowadays it is not preferred. Platelet-rich plasma, yes, platelet-rich plasma has a very good result because this is basically a regeneration occurs, and papers are also supporting. Recent evidences are coming, and this normal saline usually we do not prefer. We prefer 5% dextrose because of its regenerative, proliferative effect. And thank you so much. That's all. And these are the few important things we should remember. Thank you so much for your kind listening.
Thank you, Dr. Smati, for your nice presentation. Very well marketed video shown by you, and thank you very much for most.
So the last topic for this session is gasoline ganglion radiofrequency ablation, a very popular procedure for all the pain physicians. So I'll welcome Dr. Anjali Kumari for that.
Good afternoon, everyone. So without any delay, I'll just start my topic on radiofrequency ablation of the gasoline ganglion. So disclaimer, a duly informed consent was obtained from the patient for the use of his image and videos for this education purpose, and every effort has been made from my side to safeguard and conceal his identity. So just to give an overview where this procedure is being used, it's trigeminal neuralgia, which is a severe paroxysmal, commonly unilateral facial pain along the distribution of trigeminal nerve, which is the fifth cranial nerve. Pharmacotherapy, carbamazepine is the drug of choice, but there are other drugs like oxcarbamazepine in patients where carbamazepine has side effects, baclofen, lavandrogen, and gabapentin. And some newer studies have also seen the effect of intranasal 8% lidocaine spray, although it's not very easily available. So the indications for radiofrequency ablation: classic trigeminal neuralgia, refractory to pharmacotherapy, elderly patients who are unwilling for surgery, patients with multiple comorbidities, unfit for surgery, and recurrence after previous procedures. The anatomy review, I would like to show you where the trigeminal nerve is coming from. It arises in the base of the skull and gives three branches: ophthalmic division V1, maxillary V2, and mandibular V3. They all three exit from their specific foramens. But in order to approach the trigeminal ganglion, we can only approach it via the V3 foramen, that is the foramen ovale, from where you can see the mandibular nerve is coming out, and it can be visualized when we see the submental and ipsilateral oblique view of the skull. In my next proceeding videos, I'll make it more clear to you. So this is the pre-procedural checklist which has to be followed before taking the patient. The consent, the site has to be confirmed, adequate NPO, drug history, which is very important. If any ongoing antiplatelet or anticoagulant is there, we have to stop based on the data which we have regarding stoppage of drugs. Lab investigations like CBC, coagulation profile, again very important, and the viral markers. IV access, antibiotic, and other things regarding the emergency as the workstation, emergency drugs, airway card, and all the monitors have to be attached because the local anesthesia can cause toxicity, and we are very close to the brainstem. So the patient position, it is supine with slight head extension. We place a very small pillow just below the shoulder blade. As you can see in this picture, the arrow shows the pillow which was placed. And this is the final position after painting and draping and with the C-arm. So the first step is to take a true AP view and then take a submental view with ipsilateral oblique tilt to visualize the foramen just medial to the coronary process of mandible. As you can see in this video, we first take the AP view, then we are tilting it towards the caudal side to take the submental view. Then we'll tilt the C-arm to the ipsilateral side, the side which we have to do. In this patient it was right. So now the final position will achieve a submental ipsilateral oblique view. As you can see in this picture, I have highlighted the red part is the mandibular process, the coronoid as well as the conoid. The blue line shows the maxilla, the lateral wall of the maxillary sinus, and the green arrow indicates the foramen ovale. A very beautiful foramen ovale is visible. Now step 2 is place the pointed tip at the foramen ovale and infiltrate the skin with local under sterile precautions. This is how we have done it, and this is the C-arm view which we'll see. The step 3 is to introduce the 20 to 22 gauge, 10 cm, 10 mm or a 5 mm active tip RFA cannula in a coaxial approach to the foramen. Gently we advance the needle in the coaxial view till it has touched the foramen and passed beyond it. Depth has to be controlled in true lateral view, which is very, very important. So this is the needle, the tip is slightly bent roughly 10 degrees for easy steering of the needle. Caution, careful not to penetrate oral mucosa. For beginners, we suggest you place one finger inside the oral cavity and then introduce the needle. So this is a small video where I'll show you how we have introduced the needle in gentle manipulation. So a millimeter I move when I ask the person to shoot the C-arm, or I do it myself, and then we see it again in the C-arm view. This is how it is done. Moving on, so this is how the needle looks in the submental oblique view and in the lateral view. In the lateral view, we have to be very careful not to cross the clivus, which you can see where the pituitary fossa is there and the pituitary is seated. So if you cross the clivus, you are in the brainstem. Step 4, after the final position is reached, as per the fluoroscopy view, you remove the stylet, insert the electrode probe and do the stimulations, which is a very important part to realize that you have reached the correct location. So first you do the motor stimulation at 2 Hz, then you see the contractions, which I'll show you in the next video. Then you do the sensory stimulation at 50 Hz and ask the patient if he has the similar type of pain which has been experiencing in the area where he was experiencing before. This is known as the sensory motor differentiation part, and it confirms the final needle position for thermal lesioning. So you can see here, it's a small video where we are showing how the motor stimulation is done. So this is the motor part, we select it, we rotate the knob, we increase the frequency, and then we see here whether the contractions are there or not. We'll note at which we get the contractions and whether they are increasing while we increasing the frequency. This is how it's done. In this part, we are doing the sensory stimulation. For the sensory stimulation, we ask the patient regarding the pain. If I can just increase the audio, you can hear. So we'll be asking whether the patient is having pain. I think the audio is not visible, but the patient will tell that he is having pain. So by that we got confirmed. We can't increase the frequency too much because the patient will have too severe pain and the patient is under local anesthesia, so you just can't make him so uncomfortable. Moving on to the step 5, the electrode probe is removed after the position confirmation and 0.3 to 0.5 ml of 1% Loxicard is given after checking for negative aspiration for CSF as well as blood. CSF is very important. If it's coming, you don't give local anesthetic. After 2 minutes, so this is the video where you can see we are giving local anesthetic. After waiting for 2 minutes, the electrode probe is reintroduced and thermal lesioning is started. So this is the electrode probe. I just want to show you in this photo if it's clear. This will introduce inside the cannula. So 3 cycles, usually we do 3, sometimes 4 can also be done. Thermal lesions are performed at temperature of 60, 65 and 70 degrees. Some people go up to 75 but it's not recommended for 90 seconds each. So this is a video where you can see, just take 1 minute. So this is a video where I can see the temperature is set, the temperature is increasing, initially it increases slowly, that is the ramp time because the patient will have a severe pain. So the temperature rise is very slow. Then for 90 seconds the cycle is done, once it reduces then it's done. So the step 6, between the lesions, we have to re-stimulate the nerve to compare motor response levels and the paresthesia. And at the end, we administer 2 mg of dexamethasone after negative aspiration and remove the needle. This is how we do it. We recheck the paresthesia as well as the motor contractions. They have to come at a higher frequency as it was before. So we are checking, the audio is not there, but the patient told that there is no pain or a little paresthesia on this side, the right side, as compared to the left side. So coming to the last slide, we observe the patient in the recovery room for 2 hours to look for any bleeding or cheek hematoma. It's a daycare procedure, the patient can be discharged on the same day. These are the most common complications where most serious is the brainstem anesthesia. You have to be very, very careful while aspirating. No CSF should be there before giving the local anesthetic. Other complications like intracerebral hematoma, meningitis, they are not that common, but yes, may occur. Masseter weakness, yes, it's very common. Rather than a complication, it's a side effect which the patient has to bear for rest of the
Actually, I think a wonderful demonstration of the ganglion radio frequency. And since a practical session and I don't think we have time for questions, anybody who has any queries regarding all the procedures can take it with the speakers during lunchtime. At this point, I would like to thank Dr. Shalina for hanging on, but however, we will not be able to take questions because we are preparing for the inauguration. Thank you so much, everybody, for a very interesting session.
Thank you to all the chairpersons and the speakers for the insightful presentations. I would request the chairpersons and the faculty speakers to proceed to the felicitation area.